I have the same disclosures, nothing changed. Non-invasive NAVA showed up in our NICU in July of 2010. We had tried it with regular NAVA. We had tried non-invasively a couple of times, but because of the inability to compensate for the leak, it hadn't been very successful. So once non-invasive arrived, we started putting babies on this. We've now done about 50 babies on non-invasive NAVA, and our experience has generally been good. Most of our babies have done well, and those that have failed have taken us a little time to work out why they failed, and we're getting much smarter at figuring these things out. We are using it primarily to prevent intubation. If we can prevent putting an endotracheal tube in our tiny babies, I think we're going to do a lot of good. And then secondly, to facilitate earlier extubation. Because it's only been with us for 18 months, we really don't have a lot of studies to look at this point. So what I'm going to do is show you a couple of cases that we've had, including some videos, to get a sense of what micropreemies look like on non-invasive ventilation. Our first baby was a 23-weeker, 650-grammer. Now remember, for the adult doctors over here, the borderline of viability is 23 weeks. Occasionally, a 22-weeker will survive, and only 50% of our 23-weekers survive. So we are talking as immature as you can get. This baby was intubated in the delivery room and treated with surfactant, and then was put onto NAVA invasively by 2 hours of life. The baby was extubated at 36 hours of age to NIV-NAVA. Let me say this again, a 23-weeker extubated by 36 hours of age. He weaned to CPAP on day 8, so he's on NIV-NAVA for about 7 days, and then to high-flow cannula 1 day later. Never looked back, never got intubated again, and did very well. Case number 2, a 26-weeker, 655 grams, and his twin brother, 620 grams. So these babies were 3 weeks older, but weighed about the same. Babies were intubated in the delivery room, treated with surfactant, extubated on the first day to NIV-NAVA, stayed on NIV-NAVA for a week, and then they were extubated to high-flow nasal cannula. And this is actually quite typical now for our 26-weekers. So the first I'm going to show you here is a video of the 3-day-old. On this side will be the 3-day-old 26-weeker, and on this side, the 3-day-old 23-weeker. What I want you to notice first is how different their skin looks. The 26-weeker has pretty mature skin. The 23-weeker has very shiny, transparent skin. Both of them are being ventilated non-invasively. We do use chin straps in our unit, which I know is not typical in Europe. You can see that work of breathing is minimal in both babies. 3-day-old, 23-weeker on this side, and a 26-weeker on that side. Comfortable, looking good. We have been delivering CPAP 2 ways. One is with the Medine prongs. These are very stiff plastic interfaces that then you put some soft prongs over that, and that goes into the nose, or the mask. And for these tiny babies, we alternate back and forth between the prongs and mask to try and prevent either nasal septal breakdown or breakdown on top of the nose. And this has been our standard until recently, then I'll show you where we've moved from there. And now you'll see the set of twins, both of them. One will be on the prongs, and one will be on the mask. So I think that little guy's on the mask, he's on the prongs, and there's their EDI signals on the side over there. And again, you can see minimal work of breathing. Both look very comfortable. Oh, I guess I got it backwards. That's the mask, that's the prongs. You get old, your eyesight goes. Okay, so very impressive. This is something that we do not see routinely in the neonatal intensive care unit. We do run into problems. 23-week baby, the same little guy that we had. He was on NIV-NAVA for 10 days, alternating between the mask and the prongs. And after 10 days, we noted the abrasion on his nose. And at that point, we stopped and we went to high-flow nasal cannula. And here you can see, as we saw in the adults, this nasty thing here right on the top of the head. We are lucky. Babies heal much better than adults. Baby skin is much better. There's a lot more growth that can happen. And 1 month later, You can see that the scar is almost invisible. He's healed beautifully. And then over Christmas, his parents brought him in to see and gave me a Christmas card. And here he is at 15 months of age, and there's nothing to see at all. He healed beautifully. The rest of him did pretty good too. We have now moved, because of these complications, we've been waiting patiently for some brilliant person to come up with another way to deliver non-invasive NAVA for our neonates, because we don't have the same options as adults. Helmets aren't good for us. Those big face masks that you saw are really not reasonable alternatives in babies who are so immature that you take your hand and you rub it over your face and you take off a layer of skin. So we have to be very, very cautious. And they've now come out with a new cannula called the RAM cannula, which looks like a regular nasal cannula, but it's very stiff, and supposedly it can deliver the same amount of CPAP and ventilation as the CPAP prongs. So here we have a little preemie that is on the nasal cannula. And again, this baby's about 25 weeks. Let me see, did I get that right? 25 weeks, 2 days old, extubated. And there he is on the nasal cannula. And he's getting ventilated. This is not just nasal cannula delivering oxygen, but it's actually over here, you can see it is delivering ventilation. The synchrony is not going to be perfect because I filmed one, then I had to film the other. But very comfortable, very little work of breathing, getting what he needs. On the tiny babies, these cannulas can be a little challenging to secure, but we've figured out how to do it, and we really don't have much trouble with this at all. And this has now become our standard way of delivering non-invasive ventilation in our NICUs using this cannula. I get there eventually. You'll get a little seasick. Sorry. There's the connection on that side is just hooking the cannula right into the ventilator. Let me ask, have any of you guys had a chance to use the RAM cannula, the neonatal world? Just a handful. Okay. It's only been out since, I think, beginning of November was when it got FDA approved and released. So we started with NIV-NAVA. We started extubating our tiny preemies a little sooner. And one day in the unit, a nurse came up to me and she said, I'm very concerned that we're extubating these tiny, tiny babies. I'm not talking about the 1,000-gram or 1,200 grammers, which now we don't even consider those small babies anymore. So we're talking about the micro preemies. We're extubating them by 1 to 2 days of life. And the nurse said to me, the concern that I hear around the unit is that these babies are being extubated too soon. They're then either having pulmonary hemorrhages or they're collapsing their lungs and they're dying or going back on the ventilator and being really, really sick. And we think you should stop doing it. So I said, well, I don't get that sense, but I'm clearly biased. So what I'm going to do is pull data. So that's why I even went looking for this, because I was addressing a concern that was being raised in the NICU rather than I was trying to do a study. So what I did was I pulled all the babies we had from 23 weeks to 25 and 6/7 weeks. So the teeny tiniest of our babies from July of 2010 to August 2011, so 13 months. And when I just lumped them all together and looked at them, they fell into two categories. Early extubation, which we did in the first 2 days of life, and they were either extubated from NAVA. If I was on, they went from NAVA to NIV-NAVA, or they were extubated from SIMV to either CPAP or to NIV, either NIV or NIV-NAVA. And then late extubation was any time after 2 days. And as I said, I didn't pick 2 days magically. It's just that's kind of the way the groups fell out nicely. And the decision to extubate was purely on the discretion of the treating physician. We do not have an accepted, followed extubation protocol for these micropreemies in our NICU, although this data hopefully suggests that we should. I found we had 22 neonates, 23 to 25 and 6/7. Gestational age fell right in the middle. Birth weight about 650 grams. 11 neonates were extubated early. 8 neonates were extubated late. And as you'd expect with these micropreemies, 3 neonates were never extubated, and they died between 2 to 4 days of age. So I include them in some data, but not in my outcome analysis. Looking at maternal and birth characteristics, this is all of them, those early extubated, those that were late extubated, and those that were never extubated. And what we see is that those that were extubated late had slightly more premature rupture of membranes, so maybe a higher incidence of the risk of chorioamnionitis, maybe. And they had 1-minute APGAR scores less than 3. There were more babies that had that. And a 5-minute APGAR score greater than 7. There were less babies that had that. So you could make an argument that at least in the delivery room, those that were extubated late were a little bit sicker. But if you look at the early extubation babies, there were at least some babies that appeared to be equally as sick in the delivery room. And then, of course, the early extubations all got caffeine. The late extubations didn't get caffeine early because there were no plans to extubate. Overall extubation time was 10 days, looking at this whole group. So we think that's pretty good. For 23 to 26 weeks to extubate the majority of them in 10 days, we like. 47% of them required non-invasive ventilation, and for an average of about 4 days. The early extubation group divided about 50-50. 6 were on NAVA, 5 were on SIMV with pressure control. And again, not prospective, this just is the way it fell out. And the late extubation group, none of them were on NAVA early, so you know I wasn't in the NICU. Our extubation results, as you'd expect, our early extubation were extubated earlier than the late. Earlier extubation at about 1.2 days, late extubation averaged about 23 days. So if you didn't come off the ventilator soon, you were going to be on the ventilator for a long time. All the other things were non-significant. I'm just talking about the significant things. And then the other thing that was significantly different was days on non-invasive ventilation. If you came off from NAVA to NIV-NAVA, you were on for 4 days. If you went from SIMV to either to non-invasive ventilation or CPAP, you were only on for less than a day. And again, that was purely the choice of the attending physician, nothing more than that. What I want you to see is our early extubation success. In our late extubation, success was 0. We never tried. But in our early extubating babies, overall, we had a success rate of 73%. That means a failure rate of 27%, which the literature talks about failure rates of 20 to 50% in these micropreemies, infants less than 1,000 grams. So we are well within the expected norms for extubation failure. And if you're comparing those on NAVA to SIMV, it's statistically the same. 67 to 80 sounds different, but with these tiny numbers, it isn't. Overall outcome data fits with what you see nationally. Mortality, about a quarter of these babies will die. Most of the 23, 24 weeks will die. Less of them would be 25, 26 weeks. Chronic lung disease in about a third, interventricular hemorrhage grade 3 or 4 in about 25%, and retinopathy or prematurity grade 3 or 4 in about 20%, and length of stay was about 110 days. These babies are with us a long time. Outcome results, to me, this tells the whole story. Early extubation, about 10% chronic lung disease. Late extubation, 67% chronic lung disease. Huge difference between whether you have that tube in for a long time or not. The other thing that really shook me up is that interventricular hemorrhage, 10% in early extubation, half of the babies in the late extubation group. You could make an argument that that was because they were a little bit sicker in the delivery room. That's why we couldn't get that tube out sooner. That's why they had more IVH. Maybe. These numbers are very tiny. But it's certainly provocative. And it fits with the other literature out there that says early extubation of tiny preemies results in better outcomes. And then finally, if you want to go to your hospital administrators and do a cost comparison, length of stay, 126 days in the late extubation, down to 95 days in the early extubation. Not saying that NAVA or NIV-NAVA did this, but certainly early extubation contributes to this. And I think NAVA and NIV-NAVA will be playing a role in this more and more. So in conclusion, babies in this tiny, tiny age group were extubated sooner, had a lower incidence of chronic lung disease, a lower incidence of IVH. And I need to talk about that for a moment. The difference between having a grade 3 and 4 IVH and no IVH is really a long-term outcome of mental retardation and cerebral palsy versus essentially normal. Forget the financial implications of this, which is immense. But think about the family implications and think about the patient implications, the difference between having a neurologically good kid versus a neurologically severely impaired kid. That alone would be a reason to try and get the tube out sooner. Our hope is that in the smallest of neonates now, we can look at this study and say that NAVA may not be better in conjunction with NIV-NAVA, but at least it doesn't seem to be any worse. And maybe it is time to start looking at it to see if we can increase our extubation success just a little bit. The support trial that came out a year or so ago showed that not all premature neonates need to be intubated immediately for surfactant. But in those that did not need to be intubated right away, there was an 80% failure rate that still needed to go back and be reintubated and given surfactant. Maybe early use of NIV-NAVA without intubation ever will decrease that failure rate of 80% to maybe down to 60 or 50%, making a huge impact on outcomes. And we need to do more studies to see if the early use of NAVA and NIV-NAVA can help us to extubate these babies sooner. I think that they can. I think from my perspective, when I take these micro-preemies and I put them onto NAVA on day 1 of life, and I see that they have a spontaneous drive, they are able to regulate themselves, my confidence level to extubate them and give them a trial on NIV-NAVA is much higher than when I have a baby on SIMV with pressure control, because I have no clue what their spontaneous respiratory effort is like. And when they weigh 500 grams and they're 23 weeks, I assume they have no clue what they're doing. I'd be wrong. So I'm hoping that at least the EDI catheter and with NAVA will give us more confidence to pull that tube and then ventilate them non-invasively. And if we can use NIV-NAVA from birth, can prevent intubation, and as a result, the combination of NAVA and NIV-NAVA can start to improve our neonatal outcomes. Thank you.
Howard, is your family still here?
In the back.
Then that was one of the most brilliant talks I've ever heard.
I know.
You're going to win a Nobel Prize for that, Howard. Any questions from the audience? I have a question. I wasn't quite sure the patients who get extubated early versus those late. I understand at birth there's no difference, but by 1 day, 2 days, presumably there's something is different, that those are the healthier babies to start with. So can you explain that?
Yeah, you know, I picked a patient population where in just about any NICU in the country, most of these teeny tiny babies are going to get intubated and given surfactant. Maybe you could argue by 25 weeks, not all the babies are being intubated, but even the big trials where they looked at thousands of babies, the support trial being the largest out there right now, excluded babies under 26 weeks because they felt that all those babies are going to need surfactant. So there's no point in looking at them. So we intubate them. We don't really argue through that whether we should or shouldn't. We treat them with surfactant, but then it becomes a question how fast we get them off. And I really think it's a personal physician thing. When I'm in there, I'm walking up and down outside the room. I've got the kid on NAVA. I've got my head in there. I've loaded him with caffeine. I'm just itching to pull the tube. And if it's 8 o'clock in the morning and I'm there all day, that tube's coming out. If it's 4 in the afternoon and I'm there all night, the tube's coming out. If I'm going home at 4 o'clock, I'll leave the tube in. At 8 o'clock the next morning, I'm back again to pull it out. I'm on a mission to get this tube out. Not all my colleagues, surprisingly, agree with this approach. So, you know, as with any group, you've got 8 physicians in there, which means you've got about 12 opinions. And you've got to just deal with it. So that's our biggest variation, I think, is physician choice.
You know, it seems to me that the outcomes are so bad in some kids and the potential impact so large that this is a great place for a clinical trial, for an RCT.
Agreed.
You know, that you might have a relatively small number of patients and have, you know, positive or negative, whatever. So I encourage you to do that. That would be fantastic.
Okay.
Howard, what about, oops, I'm off again. Hello. There we are. Howard,
Thanks for shutting off the microphone.
Turn off the other guys. Howard, the interface issue is a big problem. We spent like the last 2 years, I think, in our lab now on working on the negative pressure ventilation, like to reinstall negative pressure proportional assist ventilation, like NAVA but backwards. So instead you would work with the cuirass or with the some kind of device. We will see what it will become. But what's your take on that? Like if you can switch from, instead of going on the nose and whatever, to go over the thorax?
I think the concept's a good concept. I mean, it would be nice to have a little band around the baby that's creating some negative pressure and leave the head out of it completely so we can work on all sorts of things. Oral motor skills. I mean, there's hundreds of advantages in neonates to keep things away from their face and their mouth as they develop. Oral aversion is something we haven't even addressed over here from long-term intubation in preemies that is really a major problem. So I think that concept is great. I worry a little bit about putting it into implementation in 600 grammars who have extremely unstable chests, who have ribs that are mostly made out of cartilage, that are still going to go through a major, major structural development, as opposed to a 1-year-old or a 10-year-old or a 50-year-old who really are completely ossified and should be able to tolerate it well. In my micro preemies, the 23-weekers, where we're sucking on their skin, you can almost suck their skin off. A patch for heart rate. You take the patch off to move it somewhere, and it takes a layer of skin off with it. They're very, very, very immature. So it's got to be gentle, whatever it is we're doing.
Yeah, I think we've seen it like for rats, and that's now we talk about 500 grams or 400 grams, and what we see there is that, like, I mean, the abdomen is very compliant and it comes out very nicely, and you get like about the same efficiency, I would say, as with positive pressure ventilation. It's surprising how efficient synchronized negative pressure is.
We'll try it.
Question? The negative pressure actually leads right into my question. So on your previous talk, Dr. Stein, you hinted at, you had better numbers all around with NAVA versus pressure support in your prospective study. In fact, you had lower PaCO2s with lower minute ventilation, and so you said that you thought there was something else going on. And my question is that that doesn't sound like it's just synchrony. It sounds like there's something more. There's something better about delivering breaths triggered by diaphragmatic signal than there is by pneumatic triggers. And that my second part of the question is about negative pressure ventilation. And so, the data are pretty clear that negative pressure ventilation is not just more natural, it's more efficient. And so, you get better VQ matching and less pressure for more volume, that sort of thing. And the reason why I ask this is in our similar patient populations, post-op hearts, especially who have open chests, I found that NAVA gets me 5 to 10 points on or 3/4 of my patients I put them on of systolic blood pressure, which is a very big deal for a baby. You're worried about blood pressures in the 50s versus the 60s, systolics, and that lets me use a lot less inotropy and vasopressors. But it also changes how I manage the patients because I can't have them paralyzed and overly sedated. So my question is, do you think that's what's going on, is that NAVA is more physiologic because there is some sort of negative pressure? And do you think NAVA for negative pressure is the next step?
Well, I don't know the answer to NAVA with negative pressure ventilation, with what Krista's talking about here. I just have no experience with that. And in neonates, we really have no model to draw from on that. As far as what is improving this, less minute ventilation, better CO2 removal, I think it's all got to do with synchrony. I think synchrony makes a huge difference, not just from a timing standpoint, but what you mentioned earlier, the VQ mismatching, the distribution of blood flow through the lungs. There's adult models, there's no neonatal models, but there's adult models and animal models where they have done lung injury studies and then done synchronous ventilation and looked at reperfusion or perfusion through the lung and seeing what the segmental perfusion looks like. And the more synchronous you are, the better all the areas of your lungs get perfused and ventilated. So I really think that is what we're seeing impacting over here, is that these babies are redistributing in a better way. Now, we see this in our neonates that we have a lot of, the neonates have a lot of problems maintaining FRC, and they have a lot of roving atelectasis. And I know you have that in your smaller babies too. But when we put them onto NAVA, they resolve this on their own. We have lungs that one side is cystic BPD, the other side is scar tissue and atelectasis. Put them onto NAVA, it takes them a day or two, and the X-ray starts to become much more homogeneous, where both sides are kind of coming to the mean. In babies that get pneumothoraces, we are now putting them onto NAVA when they get their pneumothorax, because we find that they can compensate and ventilate for themselves better. And when their pneumothorax gets worse, we know that much, much quicker because the EDI shoot up. We right at the bedside, transillumination, chest X-ray, fix the problem. So for things that, I think that, as I said, it's more to the story than just minute ventilation.
Behind you, Norm.
Speaking of negative pressure NAVA, I think I must go back again to the upper airways because, as you know, with the negative pressure, you don't have any coordination between. You don't have any. I'm not speaking of NAVA, but if you're speaking of negative pressure, you must have a coordinated contraction of the upper airway dilators and the diaphragm. This would occur with NAVA. But you have to remember that if we speak of premise, the contraction of the upper airway muscles are not always coordinated with the diaphragm. So we would have to study that too. It's a great idea, apart from that.
Great. Thank you very much, Howard.